going to talk about esthesioneuroblastoma and how that comes to me in neuro-ophthalmology. And esthesioneuroblastoma is sometimes called olfactory neuroblastoma, and that's because it's derived from probably neural crest cells destined to be the olfactory nerve. And so as you will recall, the olfactory nerve, so here's your nose here, the little nerves from cranial nerve number 1 have to penetrate down through the cribriform plate in your head. And so when we have an olfactory neuroblastoma, the lesion is often centered on the cribriform plate. And it can make a mass that can go upstairs or downstairs. Intracranially, it'll be like a dural-based lesion with heterogeneous or homogeneous enhancement, but below the cribriform plate, it'll be like a nasal mass. So an intranasal mass with a dural frontal component centered on the olfactory nerve and through the cribriform plate. That's how it got access to the upstairs and the downstairs. The way it comes to us is because the tumor can go laterally. And so if it goes laterally into your orbital apex, you'll get optic neuropathy or cranial neuropathy, proptosis. These are the typical ways that olfactory neuroblastoma comes to me. The other way it can come to me, however, it can metastasize. And if it metastasizes into the neck, you can get a Horner syndrome. If it metastasizes into your brain, you can get a homonymous hemianopsia or wherever the lesion happens to be. So because of the quite variable and unpredictable outcomes of olfactory neuroblastoma, you pretty much have to work up every one of these patients. We need to confirm the pathology with a resection, ideally an en bloc gross total resection, and chemotherapy, radiotherapy may be needed, and it has a quite variable prognosis. So the thing you need to know is it usually comes to me by orbital disease, optic neuropathy, ophthalmoplegia, diplopia, but the metastatic lesions can also present to you, and you need to know a little bit about an olfactory neuroblastoma.